You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Getting the difference between a horizontal tear and a radial tear. So what are some of the things that clue us into this is a radial tear, not a horizontal tear, and on MRI?
Yeah, so for instance, if you look at a sagittal image, your radial tear or a parrot beak type tear or radial tear out to the periphery, if you think about the plane that's going in, that tear is more in the coronal plane. So you're going to see that on a sagittal image as a vertical white line, right? You're going to see it more in the central aspect of the meniscus as opposed to a vertical line in the periphery at the meniscocapsular junction of a longitudinal vertical tear. But that radial tear you're going to see in line there as a bright white line straight up and down on the sagittal, whereas the horizontal on the sagittal image as well as the coronal, you're going to see that in the tear is in the axial plane, if you will. So you're going to see the tear from the sagittal and coronal images, whereas if you looked in an axial image, you would only see it if you catch it just right. So you think about which plane my tear is in, and it's through that MRI plane that you're not going to see it well unless you catch it perfect, but you'll see it, appropriately on the other two images.
Okay. And then kind of looking at, vertical flaps and noting that on MRIs, what are, can you touch on, a flap and what's the difference between a vertical flap and a bucket handle tear?
Sure. Yeah. Some of these vertical flaps, you'll see a portion of tear. Again, you can have a radial type tear where some of that central tissue flips over onto itself and sandwiches itself and then gets stuck up in the meniscotibial recess of the medial or lateral compartment. As opposed to the bucket handle tear, where you've got a large vertical tear that would typically flip, towards the notch, just by the nature of where the tear is coming from. You're highlighting it here. These are unstable, starting often as a radial tear and then flipping onto itself, sandwiching it onto itself. These are often not necessarily repairable type tears also, because they start in the kind of white red zone and flip onto itself. And like you're seeing there, you've got a great picture there. That might have flipped onto itself in the meniscotibial recess on the MRI. You get into the knee, you flip it back over and you see, all right, well, this, depending on where that radial tear exits, if it exits all the way in the periphery in a young knee with otherwise good cartilage on top and bottom, like that picture shows, that might be something you get more aggressive on in the young patient. But if that tear stops right where you're seeing it, that's, poorly vascularized tissue that was out of place, being beaten up, that looks very plastically deformed, very rounded off edges, that looks more chronic in that picture you have there. That's probably something I'm going to clip out rather than trying to be heroic, unless it's a really young patient who it's worth a try for a bigger radial split.
Okay. And the difference between that kind of vertical flap versus these horizontal flaps on MRI, anything that you look for in particular?
Again, it's just going to be, you're going to find a propagating tear pattern from the MRI and then look and see where you're missing meniscus that you think should be there. And that's going to give you an indication of where to look for it based on where the tear pattern is. But that tear pattern will exhibit to some degree of vertical or horizontal signal in the images that you look at to give you an idea of how that tear is behaving in origin.